Hi there, I'm George Ralls. I'm the Orlando Health Chief Quality Officer. We've had a lot of questions from the community about COVID-19, and I'm joined today by 3 experts in the field that are going to help us understand what we've learned and some of the things that we're planning on moving forward. So I'm here with Dr. Edgar Sanchez, Dr. Joel Santora, and Dr. Chris Hunter. Our infectious disease expert, Dr. Sanchez, is going to help us understand some of the new treatments that they're considering on the ID side. Dr. Joel Santora, our medical director of Health Central's ICU, is going to help us understand some of the ICU perspectives. And Dr. Chris Hunter, who is our emergency physician expert, is going to give us some idea of what's happening in the ED. And I know you guys have been dealing with this before we ever saw our first case. I know you've been reading about it, you've been seeing things either on the news or hearing from your peers. And I'd like to ask, and maybe let's start with Dr. Santora, is what type of things were going through your mind when you're hearing the first cases of some of the stories coming from Italy and that sort of thing?
I think there was a lot of uncertainty just because it was all very new, and so it became very real for me when the NBA shut down, and I actually, that's when the alarms went off, and I started looking on the internet and reading what were these intensivists reading, what were they experiencing firsthand, what were the symptoms that they were seeing, mainly in China and in Italy, and I think that actually helped prepare me for when I did encounter the first rule-out patient that ultimately did become positive. Yeah,
really, really extreme things we were seeing. Did you do any special planning, anything you were changing in the ICUs before we ever saw our first case?
So we started strategizing. There were 3 main things that we needed to focus on. The first one was how are we going to manage these patients and treat them in an acute care setting? Managing fear and anxiety for our critical care teams that are treating these at-risk patient population.
Yeah, absolutely. And I'm going to go to Dr. Hunter here real quick. So I know on the ED side, you're seeing patients like we typically do, a lot of sick people coming in every day. But what changed with COVID-19? What type of processes were different? What type of, I would say like mindsets and things like that. What were you feeling in the ED at the time that we were seeing our first cases come in?
When we started seeing our first cases, we had started preparing a little bit before. Because similarly, I think everyone had their aha moment, like, wow, it's spreading. It could be here. It is here. And our first thought was for provider safety, and then it really came down to trying to identify who might have it, and how do you figure out what to do with those patients? How do you isolate them, and how do you identify them even? At the time, it started with travel restrictions, like we do with a lot of emerging infectious diseases. Or have you been to China? Have you been to Iran, Italy? And very quickly, that became moot. And then it was the symptoms, and then as we learned more about it, the amount of symptoms, the types of symptoms changed, and finally now we're to the point where we treat everyone like they're a suspected positive, and now we look for the higher risk patients versus the lower risk patients. But I think a lot of it had to do with trying to figure out who had it, and then how to keep them and the providers safe, because when it came to the care of it, none of us really had any idea yet what the best care of it was. It was really more this idea of how do we do that and how do we do it safely, and that was a big change for all of our processes in the ER, really.
And here's a question for you. So what did it take for you and teams in the ED to actually start to feel comfortable with this? What was that inflection point that you said, we got this? Was it equipment? Was it medical information? What type of changes in our process helped you get there to the point that you felt like we can manage this?
I think honestly, most of it was equipment. I think knowledge, obviously, and comfort with it. When we started seeing the initial patients, there was fear, are we going to have enough equipment? And clearly, eventually, we realized, yes, we are. But then one of the big issues for us was, how nervous everyone was taking care of these patients. How likely are we to bring it home with us? What do we do? In the emergency department, we do training with donning and doffing PPE and those things. But it was when you had a patient you thought had it, everyone got very, very worried. And I think that the experience of treating a number of those patients, once people recognize, hey, we can do this and we can do it safely, and we're not having people getting sick left and right, so we're doing it correctly. I think that really that comfort level went up. And I think the other piece was having safety officers, having people outside that really were experienced with donning and doffing and saying, hey, you're in here, this is the protocol, this is the process, this is what we're going to do next. And defining those processes, I think, makes people more comfortable.
Yeah, absolutely agree. Dr. Sanchez, what an amazing experience, I guess, from an ID perspective. There was a lot of ups and downs, a lot of emotional ups and downs, and I know that we're still seeing changes happening now. But tell us your thoughts from an ID perspective. What what were you thinking when we were first encountering things? How quickly were things transitioning? Where are we now with our ID treatment?
Sure. So, I mean, it's definitely been a wild ride. You know, us in infectious diseases, we are used to dealing with diseases that have been around for decades, centuries. I mean, even I remember training during the Ebola crisis in fellowship in Boston. We at least had some background in that because Ebola has been around for a couple decades.
Yeah.
This is novel. So there's been 7. This is the 7th coronavirus that's pathogenic to humans. 4 of them are part of the consortium that caused the common cold, and then we had SARS, which was the big epidemic in 2003, and MERS, which the second case in the U.S. was actually in Orlando in 2012. So we have some experience with coronaviruses, but this was a new animal, and so we're used to guidelines, recommending guidelines and treatment with decades of research, multiple clinical trials, and we can't have that with a virus that just didn't exist 4 or 5 months ago.
Yeah.
And so we had to get our collective brain power, the whole infectious disease department, look at modality, treatment and modalities that work with other viruses, see what could work and what didn't work. And then we got lucky here in Central Florida that we didn't get the surge that other parts of the world and country, that, like New York and Italy, because we learned a lot from what they went through. Those studies came out very quickly. Even usually studies come out and it takes a long time for peer review, for other doctors in your field to make sure that those studies are done well. This one was, let's get the information out there and then let's see what we can do about things now. And so it's just a whole different approach to medicine.
Yeah, we were operating that sort of guideline-free environment. We really were making decisions. And I will tell you that your team, the ID team, was really critical at the very beginning of this thing to help us make some of those big decisions. So tell me what you think about some of the newer sort of medications out there. I know there's a lot of investigational therapies. Folks are reading about some of the antiretrovirals. Any comments or thoughts on that?
Sure. So in the beginning, there's been a lot of different modalities, treatment proposed. I know the big one in the beginning was hydroxychloroquine and azithromycin. That was from small trials in France and a couple other places that showed maybe it could benefit some. Newer studies showed that maybe those hydroxychloroquine may not work as well. We're still in an experimental phase. There's still other big trials done being conducted throughout the country for that, so we can't really say one way or the other. The newer drug that we're optimistic with is remdesivir. That has, and I still have to tell people that this is still not the end-all be-all. We don't
not a proven
know
therapy. Right, we're still investigating.
Exactly.
Yeah.
But there has been optimism because it's decreased the amount of hospitalizations from 14 days to 11 days, which doesn't sound like much, but 3 days in intensive care using all that personal protective equipment, being in isolation, that is a big deal, even that by itself. And now there's newer studies trying to see if this, in combination with other antiretrovirals, will be of benefit. Things that we've been using for HIV and other viruses, other RNA viruses as well.
I think one of the fascinating things about being in such a novel pandemic and in the modern world is how fast we share information, and for better and worse, right? I'm optimistic about the ability for the world to react well to this, because some of the smartest people in the world, an army of them right now, are researching this, right?
Yeah, exactly.
All focused on it, and that's really cool in a scientific way. But then the issue is how quickly information is shared and the fact that things come out without peer review. We're all used to treating patients that, we started one way and then years later we found, hey, that wasn't the right way. And we've all done that, but it happens over a course of years. And in this, it's happening in a span of weeks and months. And I think for people that aren't in the medical field or the science field, it gets very confusing when they hear, hey, this works, and then find out later, well, maybe it doesn't. We're all used to hearing that. But I think a lot of people aren't used to, I think it hurts the confidence, but it's difficult, and it's interesting for me to hear the perspective of ID on that.
Yeah, I mean, I actually, for the first time in a long time, took out the pharmacotherapy books, the physiology book from medical school, took them out of the boxes and been like, well, how does this medication work, Because we're used to having the new trials come out,
Yeah.
and then you read about this. Has to be the other way around.
Yeah, we
Like
didn't
all
have the
other
answers going into this.
Exactly.
And so, Joel, I know your team is really, on the forefront of this. ICU docs are like the battleground for COVID-19, and I would say the most critical decisions being made for patients to date everywhere in the world are being made in the ICU. So tell us, what was going through the minds of your team, of your ICU docs? Let's say at the time where we had less certainty about things like convalescent plasma or the way we were ventilating patients. What type of dialogue was going on? What type of mindset was going on in the group?
I think that critical care is unique in that when you strip everything away, you're trying to fix broken physiology. You're treating what's in front of you. And so we're supporting organ systems. That is what we do. And no matter if we have these certain drugs or the wonder drugs that appear to be coming out every few weeks, some of them we don't have access to. And so we're doing the basic ABCs. We're supporting their organ systems, trying to give these patients' bodies time to beat the virus on their own until we do have something more definitive that we can routinely use.
Yeah. And when we were encountering some of those first decisions about convalescent plasma, that was a big decision on Dr. Vo's part, as she and I had discussed that decision the day that she was making it, and Dr. Makira as well. I'm sorry, it's actually Dr. Makira that started that. What was the sort of decision tree that got you guys to investigational therapies? Was it the lack of things to do? Was it the lack of things outside of the box, if you will, or was it more sort of directed? Were you getting some direction from the societies or other?
Well, I think in critical care, we're treating ARDS.
Yeah.
We're treating acute hypoxemic respiratory failure. And ARDS usually carries a mortality of 30%, but it behaves consistently. We use the tools that we've been trained to use, and these patients tend to get better. But their length of stay on the ventilator is usually around 2 to 5 days. And what we read from Italy and in Europe and in China was the length of stay on the ventilator was 10 to 14 days. And when we started encountering this, it's frustrating because you're not used to it. And so I think that creates the spark to start looking to other types of therapies, other types of treatments that
Right.
maybe can get the ball rolling and really get these patients moving in the right direction.
Yeah, that's great. And Chris, I know you have a lot to do with EMS as well. You've got a lot of experience there. I know you were the former Orange County EMS medical director for years. How did that play out? How did the interaction between the public sector, public safety sector, and the ER work? I know that there were issues related to transfer of care. I know they had their own protocols to follow, but there were a lot of things that could break down when you're handing one patient off from the outside of the hospital environment to the inside of the hospital environment. What did you notice there? What worked, what didn't work?
Yeah, we're pretty lucky here at Orlando Health to have a really strong relationship with all of our kind of regional EMS partners. And I think that the EMS agencies initially recognized that this was going to be an issue. And again, a lot of it started with provider safety and patient safety. How do we make sure the providers are safe from these potentially contagious patients? How do we keep these potentially contagious patients away from all the other patients? And then what do you do with an ambulance that had all this potential contagion in it? So we worked together to try to figure out a way that could be consistent among all of our hospitals and among all of the regional EMS agencies, which is rare, as you know, for everyone to agree on what's the right answer. And the goal was to find a way to communicate from the pre-hospital perspective. We believe this patient might have COVID-19, and then make sure that they're safely getting transported. And then when they get to the hospital, to find a way to make sure they got to the right spot. You mentioned that you're in the business of fixing broken physiology in the emergency room. We're in the business of identifying and stabilizing people, right? Mm-hmm. So I mentioned before, the difficulty in identifying these patients is still complicated, but much easier now. And stabilization has come a long way. But just finding out, trying to ID those patients and get them to the right spot was the right thing.
We had a very tragic scenario play out in Orlando back in 2016. How well do you think that prepared us, or how do you think that impacted the way we responded to this?
I think personally, what came out of that, one of the biggest benefits was the communication side between EMS and between the hospitals. I really think that the idea of us being able to communicate very openly came from that. And the other thing I would say was the amount of pride and effort that Orlando Health and ORMC puts into drilling for disasters and being ready for them obviously took off after that, because they recognized so many things that they had drilled for and planned for worked well during Pulse and definitely saved lives. So the idea of having the hospital set up, a mass casualty overflow tent and be prepared for that here, which they were, and to go through a process of saying, when do we use it and how do we use it? I think that those plans came together much quicker because of the experience that we had having worked together and being able to communicate, hey, we need to be ready for this.
Yeah, absolutely agree. So Edgar, we're not over with COVID-19, right? This is going to be with us for a while. What does it look like moving forward? Now, I know, we're going to encounter, I expect a low level of cases like this for many, many months to come. But in terms of like achieving a high degree of sort of clinical excellence, what does that look like for us?
So yes, it's not over. The virus is not defeated yet, and really it will be with us until we can get enough people with immunity to this virus, and we can go about it hopefully in the route of vaccine or herd immunity, where 80% of the population, anywhere from 60 to 90% of the population ends up contracting this, which would be a scary thought because that would result in millions of deaths.
We've all been talking about that. I know that it's on everybody's mind. Where are the patients that need health care right now? Because we know that they are not coming in for the care the way that we would want as providers. We know that this situation has scared enough people to stay home when they have really serious things going on. We've seen patients with chest pain, seizures, all types of serious medical issues not come to the hospital out of concern. So you mentioned several things that we have in motion now that we are sort of like lessons learned that help us maintain a high degree of quality of care for the COVID patients. Also helps us maintain safe environments. But Joel, what do you think about that in terms of the messages that we want to get out to the community about, coming back to care when we can maintain that safety for them?
I think that 2 months ago there was fear and anxiety, and you even said it. You were more comfortable with dealing with these patients, with treating them, and so I think that we're ready. I feel confident. I feel comfortable, and so the community needs to know that when they come to the hospital, we're going to bring our A game. We're going to stand up against this, and we're using the information that's constantly changing. But I think this is something that we have to do. Yeah,
and do you think that? I mean, in some ways, I think there's a point where the risk of just the thought of COVID actually presents more of a risk of people than COVID itself, if you will. If you have patients who are avoiding care for serious medical conditions because they're concerned about something that we have managed very well. How do you mitigate that risk? Chris, what type of things go through your mind when you think about that?
It's interesting. I also feel much more comfortable now, and I think that in flattening that curve, we all know that flattening the curve helped not save lives by avoiding that sort of surge, but it also bought really valuable time. And when we talk about the kind of therapies and things we have now that didn't exist or we didn't have access to before. I think that our ability now to isolate and be cautious and what we have in place right now makes me feel very comfortable that you can safely come in and out of the hospital and get treated. I think that concern is always going to be there for people, and I think it's important that people understand that that everyone's doing everything they can to avoid any sort of thing like that happening. I can tell you as someone who comes into the hospital multiple times a week that I feel very comfortable coming in and out of the hospital, going home and seeing my family, doing the things that I know I'm supposed to do. And so I feel like we have the protocols in place to keep people kind of separated and safe. It does worry me that people would avoid emergency care because of their concern for this kind of theoretical thing. It's one of those things that happened related to a pandemic that I never expected. I thought about surge and I thought about the sick people and what they had and how we treated them. And the thought never crossed my mind that what would really happen was we would start not seeing a lot of these people until it was not even too late for some of them, but very late in the game for some of these emergency illnesses. And I wasn't expecting that. I got to be honest. I don't know if any of you weren't. It was not. It wasn't anything at all that I was imagining. I was imagining we were going to be busy, no matter what. Busy.
We did. We used to hear about the quiet before the storm, right? Remember, we all heard that. But a lot more of that than I expected.
We think about for us hurricanes, right? When the hurricane's coming, our hospital doesn't do that. We build capacity. The ER usually slows down quite a bit. Everyone stays home, and then after the storm passes, a lot of people come in, and a lot of them have nothing to do with the storm. It's people that were sick and couldn't see their doctor because it was closed. People get hurt doing stuff, people that miss their dialysis, people that can't get their medications because pharmacies were closed. I was expecting that. And what we had was people not even being willing to do that, and then by the time they come into the ER now, they're very sick.
Yeah.
So it's difficult because it wasn't something we expected. But I think it is important to get that message out that it is safe to come, and certainly staying home because you're afraid of something that is very unlikely to happen versus something that is happening, like a heart attack, is a big deal.
That's a real, exactly, imminent, threat to your health. So here's a couple questions for you. I'll ask you each the same thing. I'm really curious to sort of pick your brain here. So what was your sort of biggest takeaway from COVID-19, number one? Number two, what did you do to sustain yourself through all of the uncertainty and pressure and work that you were under? What type of personal things did you do to keep yourself going?
Well, truthfully, one of the things, I just went on vacation right before this happened, actually.
Perfect. Okay.
I landed on. I had it wasn't vacation. It was a conference, an infectious disease conference in Hawaii. And then I arrived that Monday.
Yeah.
I arrived that Monday, and Wednesday the NBA closed down, and I was like, oh my God, what is going on? And so I had a lot of downtime and a lot of relax beforehand. So that helped a lot. But then, when the stress levels did come up, it was very hard. I mean, the gyms are closed. That's one of the ways I usually let off steam. So a lot of running outside, a lot of catching up with friends. As you guys are doctors as well, you guys probably have a lot of doctor friends around the country, and just talking to each of them and seeing what they're doing, catching up with them, making sure they're all good, was therapeutic for me. And talking with each other and seeing people in the same boat in your hospital doing the same thing.
Yeah.
And I also actually. I found a lot of solace in reading about this virus, especially early on. I felt like the more I knew about this virus, of at that time limited information, but then more as time went on, I became more comfortable in treating patients, and even my own stress level as to what will we do if those hordes of patients come. And I felt comfortable that I could achieve that when after a certain amount of time.
Joel, tell me, so biggest lesson learned, and what did you do to sustain yourself as we were going through this?
I would say the biggest lesson learned is that when you're treating something new that you haven't been up against, you really just have to be patient. You can't use the previous experiences that you've used in your training and your experience in treating these critically ill patients. You can't apply that to these patients, and so that's a unique experience that you have to start over. And I agree with Edgar in that reading actually helped. It helped because you felt like you had some type of control over what was going on. And I think that another thing was to actively seek out your team members and make it an effort to stay positive.
Yeah.
We're just going to work, and we're doing what we do because we need to.
Yeah, it was great observations. Yeah. Chris, what about you? Biggest lesson learned, what did you do to keep yourself going?
I think my biggest lesson learned was just how unbelievably complicated every little system that I take for granted in healthcare is when something is happening across the entire world.
Yeah.
We work together on the lab and trying to do diagnostics, and every little piece of that I'm so used to as being a physician, clicking a thing, getting an order, getting it done, and not thinking twice about every little step that comes from how the order is, to where that sample goes, to who collects it, to how long it takes to get it, to whether you trust that result, to everything, all those pieces, and how a global supply chain, and how when everyone's looking for the same thing, how that affects it. To me, just realizing how complicated, and that was just one step of a million of those, finding out just in how complex our hospital is and our healthcare system is. How I personally got through it better, we got a puppy, which increases your happiness by like 500%.
That made you happier? Usually makes most people crazy.
No, I think my way of dealing with it, we've known each other for a long time. I have a hard time running away from a fire. For me, the first few days, I was kind of trying to relax when I was off and do the things I normally do, and I just couldn't. It wasn't making me happy at all.
Yeah,
so,
for the record, Dr. Hunter used to call me about twice a day saying, what can I do to help? And
basically, I wanted to get involved because I could sense that that there was this thing was happening and it was out of all of our control. And I wanted to get involved in trying to help our efforts. I don't think I did much to help it, but it helped me.
Absolutely.
Getting involved helped me. I think feel like I had more control over the situation, so at least I could say, all right, I'm doing what I can to try to figure these things out.
Right.
And just spreading your knowledge to as many people as you can in the hospital. I mean, anybody from the nurses to other doctors to ancillary staff. It really helped my anxiety, because when I saw people started becoming more confident in how to treat these patients and not nervous. And these are the day-to-day people I see every day. It helps me as well because when you see when you see a lot of people worked up, you get worked up, and so just spreading that information as well and working together as a team, it's been great. You know?
It was the first time I would say in working in our ER where I could sense kind of palpable fear among our staff, the physicians, the nurses, everybody. And that's saying a lot because our ER sees a lot and has seen a lot. It was the first time I felt that way. So to me, that was really eye-opening, working with people who I've known for many years who were clearly really concerned about how this would affect them, their family, everyone else. I would say that was truly eye-opening to me. So I think that, you know, we've all mentioned getting comfortable with the patients, getting comfortable with having, okay, these are the protocols, this is how we're going to do it. That really changed a lot because I don't sense that anymore in our ER. Everyone's like, okay, here it is. But those first few weeks, you know, and again, thankfully, we didn't get that overwhelming surge. But even then, just with the amount of patients we were getting, there was a real palpable sense of fear that was new to me.
And I think it goes back to Joel's comments about being patient. Like we had to wait until we understood what to do in some cases. Like we could do what we knew, but we had to be patient with our uncertainty and just tolerate that. And I think once we got used to, okay, we aren't going to get it all figured out day by day. It's just going to come to us with time. Let's just do the best we can. I think that patience part was really something new for me as well. Because usually in medicine, you know, we have a lot of information provided to us. In this case, we had to really wait. I'm hoping everybody enjoyed that conversation with our experts today. Thank you so much for being with us, and thank you so much for choosing Orlando Health.